Hello, this is a bioidentical hormone therapy lecture. I'm JP Saleeby, Director of Priority Health Academy, and today's focus will be primarily on the female bHRT lecture. We have to remember that hormone therapy applies to both male and female genders, but that's a lot of material to cover in one lecture. And this is actually part A and part B together. So it's going to be about an hour-long lecture. So let's get started. To start off with my disclosures, essentially nothing to disclose here. To start off with, let me go over the objectives for this lecture. We will be talking about an understanding of the definition of bHRT, the pros and cons of hormone therapy, both bioidentical and synthetic, support of balanced hormones as far as what the science has to show for us, and its impact on cardiovascular, anti-cancer, cognitive function, all related to bHRT. Then we'll also wrap up things with dosing and delivery systems, and then we'll discuss herbal alternatives for those who do not wish or cannot have either synthetic or bioidentical hormone therapy. Bioidentical hormone therapy is sort of a huge topic to discuss in detail pertaining to both sexes. So for the purpose, again, of this lecture, we will limit it to female bioidentical hormones and also limit it to a discussion of sex hormones, because bioidentical hormone therapy can cross over to things like adrenals, thyroid, growth hormone, etc. So hormone deficiency syndrome, and especially in women, we see some fatigue, low libido, a decline in cognitive function, oftentimes insomnia, depression or anxiety disorders, weight gain or difficulty with weight management, muscle and bone loss. There can be migraines, either recurrence of childhood migraines or new onset, increase in heart disease, and that's very important, and also an increase in some, if not all, types of cancers. And of course, the elephant in the room is osteoporosis for women. Women may also suffer from, either in the peri or postmenopausal or surgical menopause period of time, hot flashes, night sweats, feminine discomfort during intercourse, and decreased interest in intimate relationships. Symptoms of menopause are many, and I'm going to list a few here. Traditionally, we think of that as hot flashes and night sweats, but it also can be related to vaginal dryness and atrophy, or anything in that little triangle down there in the urogenital area. We're talking weakening of the pelvic floor, which can attribute to things like vaginal, uterine, bladder prolapse, rectal prolapse even. So along with the dryness and atrophy that can occur, which can lead to dyspareunia or pain on intercourse, there are other things too, like interstitial cystitis, frequency of urination, and incontinence to be considered. You also see dryness and thinning of the skin, nails, and hair. Bone loss is a big one because that leads to osteopenia and osteoporosis, which actually increase the risk of fractures in women in their upper decades of life, which can increase morbidity and mortality. Mood swings, both up and down, and of course decrease in the sex drive or libido. We can also see cognitive impairment or issues with memory, brain fog, memory loss, and it does increase risk of Alzheimer's disease. Fatigue, lack of energy, and a lack of a sense of well-being are also problematic. Of course, if I mention wrinkles to a new patient seeking bHRT, that's all I need to say. And I did scour the internet for a picture of a woman who's looking a little older than her actual biological age, and that's pictured on the left. But, wrinkles around the mouth and the eyes are indicative of an estrogen deficiency. You can see headaches, insomnia, heart palpitations, and again, psychiatric manifestations of depression and anxiety disorder. And as we mentioned before, urinary dysfunction. And finally, a few more symptoms or signs worth mentioning here associated with menopause: weight gain, ocular changes, not only visual or vision changes, but also dry eyes, dental changes involving the gums and the bones around the dental cavity, as well as tooth loss and dry mouth, hearing changes, and hair changes, often seen as tough or rough hair and hair thinning. And it's all about balance. I am in my private practice not so much interested in providing super physiological doses of any kind of hormone to my patients, even though a lot of men see me for that in the sort of bodybuilding movement, and that is actually dangerous and is not in alignment with functional medicine. But defining bHRT, we need to basically distinguish that from synthetic HRT. So synthetic hormone replacement therapy uses chemicals that are unique, not necessarily considered natural, both in their chemical structure nor their ratios, and using in those unnatural ratios, which is intended to mimic natural hormones in the body. By contrast, bioidentical means that the hormones that are used for replacement are chemically, structurally the same as what our organs produce, whether it's the testes, the ovaries, the adrenals, etc. Also, when we talk about bioidentical, we're also talking about the proper ratios. Let's say the ratios of estrogens to progesterones that are seen normally in women in their 20s and 30s. HRT, which is hormone replacement therapy, can be a combination of those, maybe synthetic or non-synthetic or natural. So you have to be sort of specific. That's why we put that little lowercase b in front of HRT to designate that as the natural bioidentical. Again, it is not the purpose of this particular lecture to get into all the natural bioidentical hormones out there that can be replaced when found to be deficient in people. But I will say that the ones asterisked here, like estrogen, progesterone, DHEA, testosterone, will be the focus of this lecture. Obviously, there are other hormones that can be replaced, like pregnenolone, melatonin, growth hormone, and hydrocortisone. We have to realize that our foundation, our building block of our hormones, start with the cholesterol molecule. So cholesterol is not all bad, and I have another lecture entirely on the proper functions or the main functions of cholesterol in human beings, and it's not to produce plaques, as our cardiology brethren would have us believe. We see adrenal glands along with our testes and ovaries. So not only our sexual glands, but also some additional glands produce, and they are all, at least the steroid hormones are derived from cholesterol. You have pregnenolone, which then metabolizes to progesterone and then cortisol. It can take another track to go to DHEA, dihydroepiandrosterone, and then go along down the path to testosterone and the estrogens. You also have adrenal glands producing aldosterone and adrenaline and noradrenaline, or epinephrine and norepinephrine. To dispel any kind of misconceptions or myths about what we're talking about here, let me at least describe or identify some synthetic hormones that are out there. So Premarin, obtaining its name from pregnant mare urine, a very clever way of wording this or naming this sort of substance that's given to women, is actually derived from horses, which is natural, but it's natural to horses, not to women. So not everything can be distilled out of that, and the ratios may not even be proper. But for example, equine, and there are many other equine estrogens in this formulation, that are foreign to humans and I don't think have a place in women. Provera is a synthetic progestin. It is a synthetic form of something similar to the natural progesterone. And these were the mainstay because these were promoted by Big Pharma to many practicing doctors, obstetricians, family medicine doctors as the proper way to give women hormones for many, many years, sort of until the Women's Health Initiative study came about and there were some issues with that. And then all of HRT, that's the synthetic and bioidentical, was sort of frowned upon for many years until re-examination of the Women's Health Initiative data was undertaken just a few years ago. By contrast, natural bioidentical hormone replacement therapy are usually derived from natural sources. So they're usually plant-derived and laboratory manipulated estrogens. That's estrone, estradiol, and estriol. And they are made bioavailable in the laboratory to mimic the ones that our bodies produce in our ovaries and adrenal glands. The body's cell receptors actually see these type of hormones as coming from our own body. Many of them are derived from soybean for the estrogens, but you can't just crunch up a bunch of soybeans and rub that paste on your skin or eat it and expect to have the same effect. Progesterone, on the other hand, is based on chemicals derived from the wild Mexican yam, for instance. That's the majority of where that comes from. But it has to be further manipulated in the laboratory to have the same effects. And again, you can't just take a wild yam, cut it open with a machete, and rub that on your skin and expect to have a progesterone effect. That just will not happen. Issues with HRT, especially synthetic HRT. Big study was done and continues to be a point of data collection is the Women's Health Initiative, or WHI study, which started in 1998, and the first reports started to come out on the data in 2002. And it did show some detrimental effects outweighing the beneficial effects of HRT in women. Now, this left a very bad taste in a lot of doctors' mouths at that time. So many physicians practicing in their clinical practice in that time period basically stopped using HRT in all forms. And it was widely publicized in the media, and HRT sort of dropped off the radar for many doctors. This kind of came about, there was a change back in the mid-2010s when there was a re-examination of some of the data, and it was realized that some of the data was not correctly published or examined. New studies showed beneficial effects on cardiovascular systems especially, and all-cause mortality when younger women and early postmenopausal women in the early stages were started on HRT. Today, HRT options have not changed much in public opinion amongst many providers, and that's unfortunate. There's got a lot to be more education and training for doctors to kind of embrace again the HRT concepts. And once again, with regards to the WHI study, not all HRT is the same. So with the Women's Health Initiative, the use of synthetic replacement hormones was basically ruling the day. You had conjugated equine estrogens paired up with progestin, the synthetic progesterone, that showed problems. When you look at today with bioidentical hormones and put those into the picture, you don't seem to have the same negative side effects or negative effects that you see with the synthetics. But there's not a lot of money being put in to the study of bioidentical hormones because Big Pharma usually sponsors these studies and they don't have a financial incentive to do so with products that they cannot patent and make money off of. So these are typically smaller studies, less powerful, and they're not published in big journals. There's definitely some benefit that affects regarding breast cancer, heart disease, osteoporosis, cognitive function. And I've listed some references here. These are links you can take to basically back up what I'm saying on these slides in the medical literature. And you'll see this throughout the course of my lectures and at the end. Well, this is a very strong statement, but I'm going to say it anyway. In my personal opinion, and this is my personal opinion, it is after over 25 years of personal observations in my practice, along with the most current literature that's being published, not stuff that was published 2 decades ago, but current literature, I would have to say that prescribing synthetic progestin and conjugated horse estrogens are bordering on malpractice. And I would never refill any of these or implement or start any woman on these types of synthetic hormones. And I would caution you all to follow the same advice. I'm going to take organ systems by organ systems one at a time here, moving forward for the next few slides. And we're going to look at the benefits of HRT with regards to the heart or cardiovascular system. So heart disease kills more women than all cancers combined. 4% of women are diagnosed with breast cancer annually, but 44% of women are diagnosed with heart disease. So let's get real and let's focus on what's really taking out more women. We know that the lipid profile is adversely changed in postmenopausal women with higher total cholesterol and triglycerides with lower levels of the good cholesterol, i.e. HDL, and possibly their HDL mapping. Now, this has been published in some high-powered journals, including something published in the U.S. Pharmacist's Journal just 2 years ago. And I've noted those 2 references if you want to check those out below. Anyone out in the audience know me well, you know, and I'm not a real big statin fan. Now, I don't have an aversion of placing a patient on a statin drug when absolutely necessary and all other interventions have been exhausted. Probably in my entire practice, I have 5 or 6 patients taking statin therapy, but they're being protected by other agents like coenzyme Q10, L-carnitine, and a few other things. But the vast majority of my patients do not take statins because I think they're very unhealthy and harmful. There has been reported in an academic journal where women taking statins for more than 10 years had an 83% increased risk of invasive ductal carcinoma and a 97% increase in invasive lobular carcinoma of the breast when compared to controls not taking statins. So that alone would kind of make me think twice about putting women on statins for long term. Use of the safer bioidentical hormone replacement therapy versus statins to reduce CVD in women is a very good idea. I'm not going to read all of these, but these are some fairly powerful journals that have reported in recent times, as late as 2020 even, the use of HRT for CVD protection. Now, you can pause this presentation at any time and re-reference these group of journal articles. And this is not an exhaustive list. This is what will fit on this slide, actually. So realize there's a lot of data out there. There are a lot of journals. And to support the use of HRT or bHRT in cardiovascular disease in women and in men, too. And it's just a matter of looking and reading the right journals, not just have it distilled for you by someone visiting your office that's promoting a drug. With regard to bone health, and we look at osteopenia, osteoporosis, there's probably no stronger an intervention at preventing bone loss than bHRT. When we compare the sexes, we see a lower rate of men with osteoporosis. Yes, men get osteoporosis, but probably 1 in 4 compared to women. And it's because we have a very powerful, strong anti-bone loss hormone called testosterone coursing through our veins. Now, when women reach menopause and we have our progesterone and estrogen tank and also our testosterone drops, you're at a higher risk. Now, of course, we do the basics first. We want to make sure our vitamin D level is appropriate with adequate serum levels. We want to make sure that we don't have a parathyroid hormone issue just eating away at our bones. Want to make sure we've done appropriate DEXA studies and bone turnover markers. But when all that's said and done, and also looking at thyroid, I don't want to forget that. That's an important one. We need to look at sex hormones as a way, especially balanced bHRT with DHEA, your estrogens, your protective estrogens. We kind of leave E1 off because it's not so protective and may be the culprit in some cancers. We can use progesterone and, of course, testosterone as powerful tools for osteoporosis prevention. Studies that we use in our clinical practice are a DEXA study in some of our older patients. Insurance will typically not pay for it unless it's every 2 years and beyond a certain age. We don't like to wait till a woman has already lost 30% of her bone mass to document it with DEXA. So sometimes we'll order it and have it paid out of pocket just to do the right thing. I also use the C-telepeptide or the beta cross-lapse test. We also refer to it as the CTX, which is a serum bone turnover marker. You can get the NTX and the CTX as urine studies, but we find the blood is very consistent from measurement to measurement. Sometimes we'll also use osteocalcin, another biomarker or bone turnover marker. Frequently, you can run this every 3 months if you want, or every month, depending on if you're managing a severe case of osteopenia and want to prevent osteoporosis. You don't want to wait a whole year before remeasuring. You can adjust therapy along the way and repeat these biomarkers to make sure that you're on track. You'll also want to get a PTH, parathyroid hormone, and serum calcium levels. You shouldn't ever start treating osteoporosis with heavy-duty agents unless you're assured of the fact that your parathyroid hormones are in correct working order and levels. Also, don't forget thyroid function tests. The HSTSH, free T3, T4, or free T4 and reverse T3 are the ones we typically will run. Both hyper and hypothyroid, so overactive and underactive thyroid, will lead to osteoporosis. So you want to hit that sweet spot with levels ideal in functional medicine terms, not the standard reference ranges seen in kind of traditional mainstream medicine, but rather the functional medicine levels. You want to check for renal studies. One of the worst things is renal insufficiency or renal failure and its effects on bone health. Vitamin D levels are rather important, and since D is activated in the kidneys, that might have something to do with why renal function is important with D production and activation and bone loss and bone health. And then, of course, you have your sex hormones that we mentioned earlier to be evaluated. So bone loss is a very preventable disorder. There's a high amount of morbidity and mortality associated with fractures in women, hip fractures especially. So you don't want to wait and start treatment when it's recognized that there's some apparent bone loss. You want to get on it early. So women start building bone when they're pre-menstrual. In other words, before they start menstruating or menarche. That's when bone is laid down, calcium into the bones, I'm saying, and the architecture of the bones is built. So it's super important that young girls maintain a healthy diet and exercise to help with this. This is the time, that narrow window in which they build their reserve for the rest of their lives. As soon as a woman starts cycling, as soon as a little teenage girl starts having her first period, things plateau as far as building up that bone mass. And then for the rest of her life, it's like a slow downward trend. It's like a very slow drive down a hill to osteoporosis. So it's super important to identify this early. Some women are driving down a steeper slope than others, and you want to sort of get on top of this early, because once the architecture is gone, you're not going to reclaim that. You can reclaim minerals, and in fact, using bisphosphonates, they can really pack on the calcium, but it's going to be brittle bones. And there are many studies that show that fracture rates don't actually drop too much when you use bisphosphonates or some of these other sort of biologics to help with bone health. The high cost of hip fracture in terms of pain and suffering, disability, and monetary costs. So there's a study published, and I have it down here. You can take a look at it. Hip fractures are associated with significant morbidity and mortality, loss of independence, and financial burden. In usual care, the reported one-year mortality rate after sustaining a hip fracture has been estimated anywhere between 14% and up as high as 58%, depending on studies. Now, when I put this lecture together about 4 years ago, it's been updated since, but it was around 50% mortality rate within 1 year, all-cause mortality after a hip fracture. So devastating to women, very preventable. Don't let this fall through the cracks. To digress a bit, we'll talk about some osteoporosis prevention because it's such an important topic. And you have to have good balanced bHRT, especially your estradiol and estriol, along with progesterone and testosterone. You want to make sure you keep your eye on cortisol levels and keep them balanced. Too high, you tend to lose bone mineralization. And keep serum levels, serum vitamin D levels, greater than 50 nanograms per ml. That was pre-COVID. Actually, post-COVID, I like to keep it 60 or better. So somewhere between 60 and 80 nanograms per ml serum levels are ideal. You can support that by the use of vitamin D3 and K2, asking people to go sit out in the sun. While that does build up some D, a few caveats there. Number one, you have skin cancer and photoaging. And second of all, you'd have to spend a good bit of time in the sun. It is self-limiting, so you'll never get toxic with D. But as soon as you get home from the beach, what do people do? They take a shower with soap, and you're basically washing off all that very superficial D generation from the top levels of cholesterol in your skin activated by ultraviolet light. It takes 24 hours for that to get in your bloodstream, then go to your kidneys for activation. So if you're coming in from outdoors where you might want to jump in the shower and clean off, you're basically washing all the D that you made that day down the drain. So don't depend on that type of exposure too much. Okay? Support with boron and collagen 1 and 3, and either 1 through 5, matter of fact. And there are some fantastic bone support formulas. Just check around. Jarrow has several that they use, the bone-up formulations. Strontium, which is a rare earth element, is also sometimes found in some of these products, although there's controversy as to whether it works or not. But a lot of these studies came out of the former Soviet Union, and there seems to be more weighted yes, it helps versus no, it doesn't. So check into those, and there's some references below. Again, some references here on the use of HRT for osteoporosis for your edification. You can pause and check out these links if you so desire at your own pace. So let's look at the cancer here, the benefits of HRT with regards to cancer. A look at bHRT and an anti-cancer effect is important because we need to dispel this 20-year-old myth. Again, some of it emanating from initial data examination from the Women's Health Initiative and some other studies, that estrogens and HRT cause cancer. Actually, the opposite is true. And, you know, they say 17 to 20 years before what we're seeing published in the literature now actually makes its way into standard care in mainstream medicine. That's a long time. That's about 2 decades. We don't really have time for that. So we need to kind of get caught up with this and dispel these myths that estrogens cause cancer. Now, it depends on what type of estrogens and if they've been methylated or not. So there are tests you can do to determine if a woman is converting the right way and if she's in danger, and you can take action. But by and large, the evidence now supports the use of balanced, appropriate, bioidentical, natural hormones to actually prevent or lower risk of cancer. And there are some publications I've listed here to support that. A few labs that I like to check on my patients: I always check homocysteine. I find that extremely important, not only as a marker of inflammation, but also a biomarker for how well we're methylating. Before I do any genomic testing, I like to see this first nowadays. Make sure the homocysteine levels are below 11, better yet if it's below 8.0, and that assures a good methylation pathway that's functioning optimally. The use of methyl donors like L-methylfolate, methyl B12, trimethylglycine, dimethylglycine all can help, especially if people have the MTHFR variant or SNPs. Check for proper methylation of estrogens. So the methylation pathway is important to have methyl donors available to methylate E1. So it's essential to check, especially women who are high risk for breast cancer or who have had breast or ovarian or uterine cancer, to check for 4-hydroxy-E1 and make sure that you check the ratios and that you have a predominance of 4-methylhydroxyestrone, which is the methylated version. The unmethylated version puts people at high risk for cancer, and this goes across to men with prostate cancer. Whereas if you have a higher ratio of methylated hydroxyestrogens, then you're better off. Also, don't forget to measure vitamin B12, vitamin D, and some elements like RBC tagged zinc, selenium, and iodine. I usually measure iodine urine as opposed to blood. There has been a call for very high doses, extremely high doses of iodine for breast cancer prevention and treatment. This data is still sort of not really 100% embraced or endorsed it yet. I'm still working through that. I'm all about physiological doses of everything, so we don't want to get in trouble with super high doses of any one thing. So this is a graph. You can pause this lecture to take a better look at it, but this one and the next slide actually show the pathways of certain hormones through each other and how you get down to the 4-hydroxymethylestrone and from its precursors. This slide is even more complex, and it shows some of the SNPs and hormones and genes that are actually involved in these conversions. Again, just for your edification, if you have some time to pause this and look, we're not going to get into the details of these right now, but it's important to understand how these work and what genes are involved in them. Again, a lot of evidence to support the use of bioidentical hormone therapy as an anti-cancer tool and treatment for women and men. And here's just a few. The list is pretty expansive. So we're about halfway through our slides right now, so I'm going to be calling this part of the presentation Part B, which will be the remaining slides. We have a total of 50 slides in this presentation. And from here forward, we'll talk about brain function or brain health with regards to HRT and how it's being used for cognitive support. So research findings suggest the presence of a critical period for HRT-related neuroprotection and underline the potential importance for early initiation of therapy for cognitive benefits. Too often, HRT is reserved for women who are late in the game. They've had a hysterectomy, a total hysterectomy, or oophorectomy for whatever reason in their early to mid 40s, and they're not even offered HRT of any kind. And it affects everything, chief among it, brain tissue. So HRT is actually appropriate for women even in their 6th or 7th decade of life. Even if they haven't had it for a number of years, it's never too late to start it. I like early intervention. I like getting women, the earlier you start them, the better. So if they're go menopause on you in mid-40s, get on it soon. If they've had a surgical menopause, get on it, start them on therapy. Does this last forever? Well, it depends. Again, you can get women on HRT and have that go on for 2, 3, 4 decades if you wish. It depends on the situation and what the patient's needs or desires are. So it's not a forever ever thing, but it can last longer than just treating hot flashes for a few years, which is kind of the posture and position that many obstetric gynecologist folks will take on HRT. So bHRT and mood. We know that mood swings or mood changes is a very common manifestation of peri and postmenopausal women. And there is an estrogen-serotonin connection. In something published in the JSM back in 1999, the neuronal synapses, estrogen increases the concentration of neurotransmitters such as serotonin, dopamine, and norepinephrine, and that's all in the synapses of the neurons. And then Dr. Bruce McEweed had stated in his book, published, this was back in 1981, that we conclude that estradiol may have a fast direct effect on brain membranes to modify serotonin receptor availability, while exerting a slow effect on the same receptors through an interaction with intracellular estrogen receptors in those brain regions that contain them. So there is a connection that we've known for quite a while, and we have to not forget this in considering bHRT for women for both mood and brain function. Again, here's a few articles that support bHRT for cognition and brain function. Now that we've realized some of the benefits of HRT, let's for a minute talk about some delivery systems and dosing. So oral dosing, and I must reiterate, never testosterone because of hepatic damage and hepatotoxicity. So use other mechanisms of delivery for testosterone in both men and women. Progesterone has benefit as a counter to that. So I like progesterone orally for women, especially who complain of insomnia, because part of that degradation or metabolism of progesterone will go towards something called allopregnanolone, which has an affinity for GABA receptors in the brain. So it can help with calm of an anxious patient or sleep, initiating sleep of someone with insomnia. Not 100%, but it does work very often. I never give progesterone orally in the morning or daytime. I usually reserve it for evening dosing. You also have transdermal or topical applications. About 85 to 90% of my patients in my clinical practice are on transdermal or topical. Transdermal is really the proper terminology for it. Topical refers to it like a cream you'd put on a rash. So either gels or creams, mostly creams because they are not as drying. And then you have troches, or in some cultures they call them troches, depends on where you're hearing it, what part of the world, and or lozengers is another option. Troches are beneficial. They're kind of little waxy squares, and they can be subdivided much easier. For instance, you can have a tray of troches, and you can start off with 1/4 or half dosing and work your way up. So it's easier to titrate. They go in the mouth and they kind of dissolve. Sometimes they taste good, sometimes not, depending on what's all in them. Lozengers are kind of like hard candy. You'd park it between your buccal mucosa, your cheek and your gum per se, and let it sit there and dissolve. And then of course you have injectables. There's one that I left off here that's kind of a newer trend, and that's nasal spray. Although I'm not a big fan, I tested it on myself, a new formulation that was a testosterone nasal spray, and it was supposed to be administered QID, which I thought was a little burdensome. And the other effect is that it instantly caused me to sneeze and was an irritant. So I'm not recommending or writing for the nasal sprays, not particularly for this HRT. And then there's pellets, made popular recently in the last decade or so. It's a big way to monetize a practice because you have people that have to come back every 3 to 4 months, and it's a procedure which you can bill for. Makes a lot of money for some doctors. I'm not a big fan because you have to be spot on. If you administer a pellet that is too strong, you have to wait for a washout period, and that could be miserable, especially for women in regards to testosterone. Also, the wound can dehisce. It can lead to infections and scarring. Sometimes the pellets will pop out. And this is from a guy who graduated from the Medical College of Georgia, where the Greenblatt Library was named after a world-famous endocrinologist that taught at MCG, who initially started using pellets in the 40s and 50s. That's the 1940s and 50s. In patients with endocrine problems, mostly females with fertility issues. So Dr. Greenblatt is probably turning in his grave because I don't subscribe to using pellets, be that as it may. I'll give a little bit of a rundown and contrast oral versus topical or transdermal. Avoid using oral estrogens because the first pass effect, that's where the drug goes through the liver, can actually increase clotting factors and things like DVT, PE, and also cancer because it actually can produce more estrone or E1 when delivered orally. And again, I'll mention do not use oral testosterone for hepatotoxic reasons. Estradiol to E1 conversion is higher with oral dosing. So even if you're administering E2 estradiol, it will convert more readily to E1, which you don't want. Progesterone orally, especially sustained release capsules, not the oil-based commercially available, is best. However, there's some caveats about dosing. So if something's commercially available, like the 100 or 200 milligram capsules, whether they're immediate or sustained release, and we don't write it as SR anymore, we write it as E4M. That's the nomenclature you should use when you're prescribing something to a compounder, since SR is reserved for pharmaceuticals that are already pre-made by Big Pharma. But going back to this, if you have somebody who has an issue with peanut allergy, since peanut oil is commonly used in progesterone capsules or gel caps, then if you are compounding it, you have to note a peanut allergy. And even then, some compounders are limited or restricted and cannot write commercially available dosing, even though there's a difference between IR and sustained release. So you'll have to kind of figure a different dose, like maybe 85 milligrams versus 100, or 110 or 115 milligrams for 100, just to make the FDA happy. Allopregnanolone byproduct of the breakdown or metabolism of progesterone will, again, I mentioned this before, hit some GABA receptors and help with sleep. Oral P4 is better than topical for cycling, folks who are still cycling, and also those with insomnia. Sublingual can be erratic if not compounded properly. So the lozengers and troches can sometimes cloud the issue depending on who makes them, how well they make them, and how they're taken effectively by the patient. Okay, testing, we're talking serum, saliva, urine testing while folks are on HRT to kind of keep an eye on what's happening. and this is limited to the testing. I mean, I'm not talking about other biomarkers for cholesterol and things like that. I'm kind of just focusing on your basic hormone tests, like testing testosterone, total and free, estrogens, including E1 and E2. We don't usually measure E3, progesterone, pregnenolone, DHEA sulfate, and cortisol levels, for instance. Also, sex hormone binding globulins are sometimes helpful. And things like LH and FSH if indicated. So with serum, it's good. I mean, it's easy to do the blood work because it's kind of goes along with some other serum tests you're doing. Is it good for baseline? So if somebody's not taking any therapy, a serum hormone levels are good. You get a good baseline. But with management, if they're on transdermal, sometimes serum can underrepresent what's really going on the cellular level. And so you can look at saliva or urine, but saliva tends to sometimes overrepresent what's going on a cellular level. So sometimes I'll do both, especially when I'm stuck and somebody's not happy with the results and we're kind of scratching our heads like, what's going on? Because there's lots of variables depending on absorption issues. If you're using a transdermal gel or cream and somebody has some funny skin that's not absorbing, you see that in about 10% of times with men, even lack of proper absorption or skin sensitivity due to some other things in the vehicle that causes irritation. You have to switch to a different delivery system. So just remember, serum can underrepresent levels, whereas saliva can overrepresent. And sometimes you got to use the magic of the art of medicine to kind of tweeze out what's going on. And frequency. You don't have to micromanage people. You don't have to get it every month or every 6 weeks. You can do it quarterly until they're stable, and then maybe semi-annually. Or in some of my patients who are super stable, I just measure their hormones once a year. It's expensive, especially if you're using saliva or urine to measure these hormones. It gets pretty costly. And then the other biomarkers, again, things like inflammatory biomarkers, bone turnover markers, cancer markers can be done. And it's wise if, let's say, a man on testosterone, it's wise to get a PSA. But just don't forget some of the other markers, especially depending on what you're managing their hormones for. If it's just for hot flashes, who cares? But if it's for osteoporosis, you better be running some CTX in series to make sure that you're having the proper impact. So this is a pretty complex slide. I'm not going to spend a lot of time speaking this one out, but basically it's a guide of testing steroid hormones, and that's like testosterone, estrogen, progesterone, using serum, saliva, urine, and blood spot technology. So the dried blood spot, which is the DBS, that's what that is. And it talks about endogenous, oral, topical, vaginal, troches, and pellet therapy and intramuscular therapy, and the pros and cons, and how you have over and underestimations here. It's a good slide to keep in reference and to come back to and visit after this lecture to kind of dive into this. So this will help you pick out and understand and interpret the tests that you order on your patients. Labs to consider initially, LH and FSH to make a diagnosis, E1, E2, we don't usually measure E3, but it can be done. Progesterone, testosterone, and I usually get total and free. DHEA sulfate versus DHEA, as sulfate's a little bit more stable in the blood, and it gives you sort of a better picture of what's going on. You can look at a morning cortisol level, which is a spot check for serum cortisol, or you can do saliva or urine mapping of cortisol using the CAR or cortisol awake response protocol, or not, and that's another lecture for another time. Sex hormone binding globulin, thyroid function tests, IGF-1 for growth hormone, and pregnenolone is another test that you may want to consider, and the first battery of tests. And again, we talked about serum versus urine or saliva, and those are determinations to make once people are on any particular therapy and delivery system. So this is a random sampling of a patient actually using the ZRT system of saliva, not only to look at their cortisol map, but also their other sex and adrenal hormones. And here you see the graphic representation on the bottom, and if you look at the very bottom right-hand side, the third graphic, you see sort of an abnormal cortisol response. You get that spike, the high cortisol in the morning, and then it sort of bottoms out, and we're left with some really low levels of cortisol later in the day and the evening. So that can have an effect on sleep and energy levels, etc. But also, if you look at the estradiol, it tends to come in a little bit high, and also progesterone a little bit low. So in this case, we have sort of this estrogen dominance appearing. So that needs to be corrected. Not sure if this is a premenopausal irregular menses on a female patient who's 46. So maybe her ovaries are sputtering out. I'm not sure if she's actually on therapy. It looks like she's on some oral DHEA and pregnenolone, but not on any estrogens or progesterone. So this is a classic example of a report with some abnormal findings, and you can chase these down and use this to help correct and rebalance. I threw this slide in because we're dealing with a fairly significant spike in the number of PCOS diagnoses that we're seeing now. So not only is it diagnosed with what appears on ultrasound is a lot of cysts on the ovaries, but you don't have to have a lot of cystic lesions on ovaries to make PCOS as a diagnosis. It can also be lab-driven, or it can be a clinical diagnosis based on how the patient's presenting. But I feel that recently there's been overdiagnosis of this. You typically do not have a textbook example of somebody that's being diagnosed with PCOS. They're very, very feminine, very slight build, petite women, and they come in with a PCOS diagnosis, and on ultrasound they have not a one cyst, and their laboratories actually look pretty good. They may have had a little bit of a spike in their testosterone on one test sample, but then you need to really do a full panel to make this diagnosis, because it's a terrible thing to label a young woman with PCOS when in fact that's not what's going on, and you get distracted by a red herring. But anyway, check insulin, check your FSH and your luteinizing hormone and the appropriate ratios between the two to make a diagnosis. Measure prolactin, testosterone, DHEA sulfate, E1 and E2. You want to make sure you do a pregnancy test just to make sure that's not a wrench in the works. You can look at lipid panels and, of course, glucose metabolism and metabolic situations with A1C. You want to look at TSH at least, if not a full thyroid panel, sex hormone binding globulins, adenosine and also anti-Mullerian hormone, or AMH, to wrap things up. And this is a good panel for working up PCOS if you have a patient you suspect or someone coming into the office with kind of a sketchy diagnosis that you want to confirm. In talking about delivery systems, I should have probably put this slide in a little earlier, but you know, we talked about creams and gels, and they come in pumps or syringes, or even the Topical system, which I like because it's a good, clean delivery. You just click the bottom so many clicks, and you get the appropriate amount that comes out the top, so it's easy and reproducible. You got pellets versus a trocar. Another reason I stay away from pellets is that trocar is pretty big and painful, and it just looks very menacing. And while some practitioners love it, some patients like it because it's like, you know, idiot-proof. You go in once every 3 or 4 months, you get your pellets, and then you don't worry about anything. But there's a lot of room for disaster when this happens. Injectables, troches or troches, lozenges and suppositories, oral tablets and capsules, and most of our provided by compounding pharmacies. So finding a good compounding pharmacy is imperative. We happen to have two sponsors this year, Carolina Compounding Pharmacy and Health Center in Cary, North Carolina, and Moss Compounding Pharmacy in Florence, South Carolina. Both have reciprocity to other states, so check them out and support our sponsors. I mentioned tablets and capsules. Capsules are much easier for compounding pharmacists because it requires less equipment to make a tablet. That can be some costly equipment to press those out. So capsules are usually the preferred and less expensive. And then the Topical systems, they have all kinds of syringes. The one on the left with that sort of clamshell top is actually used with that applicator for intravaginal application. You basically click out that once you apply the syringe to the very top, and it'll push the cream up into that for vaginal applications. And then you have a couple of sizes of the ones for application on the skin, like the forearm, upper arm, inner thigh, etc. And there's little nuances about application. For instance, if some woman is having some vaginal dryness and some issues with urinary incontinence because of a weak pelvic floor, I sometimes prescribe half the number of clicks per day. So let's say she's doing 4 clicks of her cream, which is, let's say, 1 ml. I'll have her do 2 clicks on her inner forearms or upper or inner thigh, and then the other 2 clicks applied to the fingertip in the perineal region, around the labia, for instance. And then if you have the patient put it on their fingers or hands, make sure they wash them very carefully and very well, because you don't want to be distributing the hormone therapy to other loved ones. Well, dosing is very personalized. No two patients are identical, so you can't cookbook it and say that one size fits all, although Big Pharma likes to do that and has done that with HRT. But basically there's lots of dosings, and that's a whole hour lecture in and of itself, and along with how to apply, like where to put it, that kind of thing. The take-home message here really is that one size does not fit all, and for those that want to embrace HRT in their practice and who have little experience, I would recommend going and taking a few more courses or do a sub-internship with us at our academy to become more proficient at prescribing this kind of therapy. I always recommend people start low and go slow. Titrate based on subjective feedback, and then 6 to 8 weeks later, once equilibrization has occurred and the hormones equilibrate within the body, then you can test either serum or saliva samples. Find the best delivery system to suit each patient. That may be some trial and error until you kind of figure that one out. Briefly on BIAST. So BIAST is a combination of E3 and E2. Usually we leave out E1, although Triest is sometimes prescribed by purists who want to give the exact balance of all 3 hormones. But typically we understand that E1 can be a bad estrogen, so we leave it off. So an option, for example, and it's not limited to this, there are many more options, is usually an 80 to 20 ratio or 70 to 30 of E3 to E2. On occasion I'll prescribe a 50-50 ratio, because E3 is the milder, gentler, although it's the more protective hormone, and estradiol is the more potent. So if you need more of an estrogen effect, you may want to increase the ratio of E2 in that combination. And depending on your goals, remember, E2 is more potent, E3 is a little bit more protective as far as cancers go. A typical starting dose, and this is again a very typical, straightforward starting dose for more people. If you want to use empiric therapy, I do a 70-30 mix. I use 1.0 milligrams of that combination per ml with 1 ml application. So usually the dispensing Topical systems will be equivalent to 4 clicks equals 1 ml. So we do 4 clicks applied to the skin every morning after showering and drying off, and you can titrate that up or down very easily. You can also dose BID, for instance, half an ml in the morning, the other half at night. The other half may be administered paravaginally for effects on the perineum. So lots of dosing options and titration ability. Okay, for progesterone, again, we talked ad nauseum about oral versus topical, so I'm not going to reiterate that so much. But the oral capsules that are commercially available usually come in a peanut oil base, so they're 100 and 200 milligrams. Prometrium is the brand name, for example. And anyone who has a peanut sensitivity or allergy, you need to be really careful with them and may decide to use an alternative. So to talk to your compounding pharmacist, as they can provide a prescriptive of a sustained release, or what we call E4M. We can use capsules that are gluten-free and dairy-free. I usually require that, and that are clean. Depending on your compounding pharmacy, some will not use any dyes or any other kinds of fillers that are not necessary. Oral doses start usually around 100 milligrams QHS, topical between 50 and 100, and then you can titrate up or down. I've got some women on 75 milligrams of oral progesterone at night, immediate release, and some actually as high as 200 milligrams. So there's really, in my mind, very, very few exceptions to go over 200 milligrams. And follow the serum or saliva levels if there's an issue with absorption. If you have folks with leaky gut or dysbiosis, sometimes the absorption peters off and you have to use higher doses. Certain skin conditions can do that with topical administration as well. So just if in doubt, follow serum or saliva levels. With regards to testosterone and DHEA, since DHEA is very inexpensive and readily available in oral formulations, I usually just do that orally. And for women, remember, don't go too hot and heavy with big doses. Start them out at about 5 to 10 milligrams. Start orally. You can do it transdermal, but why add that expense? And I've been dosing them actually in the evenings because DHEA actually can help suppress a spike in evening cortisol that can disrupt sleep. So high cortisol levels will actually suppress melatonin, and to get out from underneath that, dosing DHEA at night might be actually better. As far as testosterone, we usually start with a cream about 1 milligram per day and titrate upwards or downwards depending on their subjective feedback. It is best administered in the morning because it has a stimulatory effect, can hit some dopamine receptors, and probably not to take right before bed. Make sure you instruct your patients not to ever use the creams as vaginal lubricants for intercourse because we don't want Mr. getting what Mrs. just put on. So be very careful, especially if someone's wearing short sleeves and they're putting the cream on the forearm, inner forearm. Remember, it can take 4 to 6 hours for complete absorption to occur. So if they put it on in the morning and then hug their little kids as they're walking out the door to get on the bus in the morning, you don't want that cream rubbing off on the children or pets. I mean, they've had vets report gonadal enlargement in little pets, little dogs, because people get really sloppy with their hormone therapy. So just be careful with that. And instruct your patients. Spend some time instructing them. Don't rely on the pharmacists to do it all the time, but it should come from the prescriber in the office doing adequate patient education. So, of course, there are another myriad of hormones that can be replaced. Growth hormone, for instance, pregnenolone, HCG, and then some peptides. That's kind of on the horizon, and there's been some limitations recently because FDA restrictions on HCG and some peptides, and classification of some of these hormones as hazardous materials has all kind of gotten in the way and gummed up our ability to help our patients. But they're out there for us to use when appropriate. And then, of course, male bHRT is another 1 hour long lecture. It's just too much material to cover right now. So with the last 5 remaining slides, let me talk about some of the effects or side effects of not well-managed HRT. So women, high doses of estrogen therapy has been associated with breast tenderness, breast sensitivity, nipple sensitivity, water retention, nausea, weight gain, vaginal bleeding or spotting, headache, irritability, and depression. Now, if somebody's been postmenopausal for a while and hasn't had a period, it can be expected when you start HRT that they may have some spotting. You need to warn them that that's a possibility. And if you're cycling it, well, then you can actually restart the periods on women. They're not keen on that most of the time, so we usually give them steady state throughout the month, sort of level doses, so that doesn't happen. For women, high DHEA testosterone therapy associated with oily skin, acne, actiniform lesions, facial hair, and androgen-associated alopecia, so hair loss due to high androgens, deepening of the voice, which I've rarely ever seen unless testosterone levels get very, very high, increased perspiration, decrease in breast size, and hyperactivity or uncharacteristic things like hostility, anger, being short-tempered, that kind of thing. So watch for those kind of signs. And for the patient who doesn't want to consider hormone therapy or is not a good candidate for whatever reason, there are alternatives, and that is a whole other lecture for another time. But just to run down the list, there's a couple things worth mentioning here: a black cohosh, St. John's wort, kava. Now, some of these have estrogenic effects and some don't. They help with some of the symptoms of menopause and postmenopause, such as mood changes and things, and insomnia and things like that. Curcumin, rhodiola, rosea, holy basil, ashwagandha, very good at night for sleep with folks. It also helps adrenal and thyroid function. It is considered an adaptogen. Chasteberry or vitex, red clover, sage, dong quai, which is a type of angelica, ginseng, and some other phytoestrogens that are not only in herbs but also in foods like soy and flax and sesame. You have vitamin C and E. That has been found to be very helpful. Higher doses of vitamin C in helping with hot flashes and menstrual issues, as well as aerobic exercise. So moderate aerobic exercise can also help with hot flashes. And you better stick with this sort of worldview on our women, especially those entering their 5th and 6th decade of life. They're not old, they're classics. So just remember that so you don't offend anybody. So there are some great books to read to advance your acumen in hormone therapy and what to help direct patients with good advice. Also, these are great books for patients to read if they have questions about, well, does hormone therapy cause cancer, etc. And I'm going to go through a little bit of these, and I'm actually going to add one that's not pictured here. But I like and respect Dr. H. Gilbert Welsh. He's an epidemiologist who is, I believe, now with Harvard. He was with another institution, and he published a lot of great groundbreaking work on the use of mammography and cancer screenings for us. And he wrote a book called Less Medicine, More Health. There are 7 assumptions that are made, and he dispels some of these myths. It's a great little book to read in general, and he does have a YouTube video out there that's about 8 minutes long that summarizes that book, and it's worth watching. Also, Dr. Lee, by himself and with some associates like Virginia Hopkins, and also Dr. David Zava, who's a PhD endocrine scientist. They've written a few books that are very helpful about menopause, and other book about what docs don't tell you about breast cancer. Those are very reasonable. They've been around for a long time, maybe even up 15 to 20 years, but still hold true. And then the Practitioner's Guide to Physiological Bioidentical Hormone Balance by Jim Poletti, who's a pharmacist, is actually a good read. It's a thin paperback, kind of a manual to guide you through the steps of how to prescribe this and how to keep things balanced. The fifth book I'd like to mention, and I'll mention this in another lecture this year, is on physician culture. And it's written by Dr. Robert Pearl, who was CEO of Kaiser Permanente for about 18 years until he retired. He's a retired plastic surgeon, but continues to do work on cleft palate repair for children in third world countries. And he wrote his second book called Uncaring, about physician culture and the culture in medicine that can be very harmful to patients and physicians and clinicians. So that's a great read to kind of put things in perspective about clinician, practitioner burnout, and other issues that are brought up in that book. Great book. So if you have questions, reach out to me. I have here some contact information. Priority Health Academy does offer bHRT shadowing and preceptorships. We do also offer sub-internships as part of our 6-month-long academic coursework in functional medicine. Again, please reach out to me if you have any questions. You can reach me at saleeby.net or at dr.saleeby@carolinaholisticmedicine.com. And I hope you guys are enjoying the conference this year.